I'm going to present a 53-year-old man with 3.5 centimeters anterior solitary mediastinal tumor with sharp chest pain for 3 weeks. Microscopically, in low power, we can see that this is a lobulated tumor, multinodular, apparently encapsulated. In areas, we can see a mixture, in most areas, mixture of lymphoid cells with epithelial cells, but there are definitely some nodules that we are going to see in a little bit that shows predominantly epithelial cells that in high power show no evidence of atypia, pleomorphism, mitosis, no nucleoli. The lesion is definitely well encapsulated with no evidence of invasion of the fat. Around the capsule we can see some thymic, normal thymic structures. Flow cytometry. Most T cells co-express CD4 and CD8, an abnormal finding. Most T cells are CD3 and CD7 positive. Some T cells are CD10 positive. Abnormal cells are CD34 negative. They are also CD20 negative. They are not only surface CD3, they express also cytoplasmic CD3. Immunohistochemistry. A1, A3 pancytokeratin positive, CD99 positive in cortical thymocytes, not in the epithelial component, cytokeratin 20 negative, cytokeratin 5-6 positive, cytokeratin 7 positive, P40 positive, CAM 5.2 positive, all these markers positive in the epithelial component. CD1A is present in the immature cortical thymocytes, but not in the epithelial component. CD34 only positive in the endothelial cells, the neoplastic cells are negative. PAX-A is negative. TDT positive in thymocytes, negative in the epithelial component. Ki67 high proliferation in the cortical thymocytes, a normal finding, but if you look at the epithelial cells, it is almost 0%. Diagnosis. To classify, you have to consider that thymomas can be cortical or medullary. Cortical, if you see more than 66% lymphocyte, is a lymphocytic predominant thymoma. If you see more than 66% epithelial cell, is epithelial predominance. If you have between 34 and 66% is mixed lymphoepithelial thymoma. The medullary thymomas, another story completely different. They are generally spindle with a very good prognosis. In this tumor, the amount of epithelial cells is variable, but in some nodules is definitely close to 100%. So based on this, let's analyze the WHO classification. Is this a type A thymoma? No, it is not a spindle cell, it's not the medullary thymoma. Is this an AB? No, we don't have the spindle cells mixed with lymphocytes. B1. B1 shows abundant lymphocytes resembling normal thymus, not the case here. What about a B2? In B2, you have abundant lymphocytes mixed with some perivascular clusters of plump epithelial cells, also not the case here. What about B3? That's our diagnosis. B3, it shows areas with predominant round or polygonal epithelial cells, big clusters of big nodules, with or without atypia. So anaplasia is not required for B3, also called well-differentiated thymic carcinoma. The good news here, this is not a type C thymic carcinoma. In thymic carcinoma, There is obvious cytological anaplasia and mitosis, pleomorphism, prominent nucleoli. We don't have these findings here. What about prognosis? Microscopically, the histology is not very good to correlate the prognosis in thymomas. For example, the survival of a B2 is 60% to 10 years. The B3 is 80% to 10 years, very similar. So the best prognosticator is the invasion of the capsule. And also very important, the stage. I think this is probably a T1N0M0. It's an apparently capsulated tumor without obvious infiltration of the perithymic fat. And according to the surgeon, no adhesions to aorta, pericardium, lung, or heart. Two final questions. Why the Ki67 proliferation rate is so high? It doesn't matter. It's high in the cortical thymocytes. That is a reactive component, but the real neoplastic component here is the epithelial cells. Is 0% in the epithelial cells. And what about PAX8? PAX8 is positive in 70 to 80% of thymomas. Not all are positive. This is one of the negative cases. Thank you.